In the previous video, we talked about all the metabolic changes in type 1 diabetes. In this figure, we're trying to put everything together. So we have hyperglycemia because the liver keeps on making glucose. We have excess ketone bodies because of mobilization of fats, too much fat flooding the liver. Not all of it will go to the Krebs cycle. Acetyl-CoA will start forming ketone bodies. Also, too much acetyl-CoA will, too much fatty acids will be leading to the formation of triglyceride, which will be packaged in VLDL. We have accumulation of VLDL because we don't have enough lipoprotein lipase. Also, we have accumulation of chylomicrons because we don't have enough lipoprotein lipase. So all of this just because the pancreas is not making insulin. When we talked about the diagnosis of diabetes, we mentioned the fasting blood glucose and we mentioned the glycosylated hemoglobin. So what is this glycosylated hemoglobin? It's also known as HbA1c. So hemoglobin A1c is actually proportional to the average blood glucose concentration over the period of 3 months. So it will not tell you how much is the blood glucose now, but it will give you an idea about how much was the blood glucose on average in the last 3 months. So this is very important for people on treatment because it will give the doctor an idea whether the treatment is working or no. Another way to diagnose diabetes is by using oral glucose tolerance test or OGTT. This is usually done for pregnant women. So how do they do this oral glucose tolerance test? They give the patient 75 grams of glucose and then they measure their blood glucose after 2 hours. So it's actually a non-fasting blood glucose that they measure after 75 grams, after 2 hours after giving 75 grams of sugar. So this is mainly used for pregnant women to identify gestational diabetes. There is also the random blood glucose or the non-fasting blood glucose level in an individual with symptoms of hyperglycemia. So if someone having symptoms of polyuria, polydipsia, polyphagia, and he has a random blood glucose above 200 milligrams per deciliter, then he is most likely to be having diabetes. Just to explain the symptoms that we talked about before, why do we have polyuria? Too much glucose in the blood, this will eventually spill into the urine. And this will lead to osmotic imbalance, and therefore this will lead to polyuria. So basically, you should remember that polyuria is caused by osmotic imbalance due to increased glucose level in the urine. What about the weight loss? Why do we have a weight loss in untreated or undiagnosed type 1 diabetes? Usually, these type 1 diabetes patients, when they come to the clinic, they're already so thin because of the high rate of gluconeogenesis. They need all the precursor for gluconeogenesis, so they start breaking down fats and then they start breaking down proteins. So there is muscle wasting, and this will lead to the weight loss. How do we treat type 1 diabetes? They need to have insulin injection subcutaneously, and this is the standard treatment where they can have 1 or 2 injection of insulin. There is also other type of treatment, but this is given for intensive treatment, which is given for inpatient, for hospitalized patient. So after this treatment, they will have a blood sugar of 225 to 275 milligrams per deciliter, and the HbA1c will be 8 to 9%. So even with insulin, you cannot normalize the blood glucose level of a type 1 diabetes patient. So this is showing the normal blood glucose in a non-diabetic individual. So it should be here, about 100. And this is with the patient taking the standard therapy, so it's 1 or 2 insulin injection per day. So just to give you an idea that it is still above normal. And this is with the intensive therapy, so it's usually given for patients inside hospitals because it's very dangerous. Why it's dangerous? Because insulin therapy might lead to hypoglycemia. So type 1 diabetes or diabetic patient in general are at increased risk of developing hypoglycemia. So hypoglycemia can be dangerous because it can lead to coma and seizure, and this is particularly for patients having the intensive treatment regimen. So why type 1 diabetic patients have hypoglycemia? In normal individual, if your blood sugar goes down, there is a compensatory secretion of glucagon and epinephrine in order to promote glucose production by the liver. However, it turns out that patients with type 1 diabetes not only have problem with secreting insulin, but also they have problems secreting glucagon. And this defect can occur early in the disease, but it is always present like 4 years after diagnosis. So the problem increases with time, basically. Now we will move to type 2 diabetes. So type 2 diabetes is the most common form of diabetes. So it is more common than type 1. Type 2 diabetes will develop gradually, no obvious symptoms, and it's usually detected by routine screening tests. So a normal patient or a normal individual just going for a routine screening test can have their blood sugar tested, and they will find that they have diabetes. However, many individuals will have some symptoms before discovering that they have diabetes. So what do these type 2 diabetes patients have? They have a combination of insulin resistance and dysfunctional beta cells. So the body is not responding to insulin, and the beta cells are not well enough to make enough insulin. So in type 2 diabetes, do we need to give insulin? Usually early in the disease, they do not require insulin, and this is why they used to call them insulin independent. But later in the disease, you might need to give them insulin in order to keep the condition under control. The metabolic alteration that we see in type 2 diabetes are usually milder than the one in type 1, and mainly that there is no ketoacidosis. Why is that? Because in type 2 we have some insulin, unlike type 1 where we don't have any insulin. So again, the same diagnosis. So fasting blood glucose above or equal 126 milligram per deciliter. Here there is no virus or autoimmune attack, but we don't know exactly what happens. An acute complication of type 2 diabetes that can happen in old patient is the development of what we call a hyperosmolar hyperglycemic state, and this is where they have severe hyperglycemia and dehydration along with some mental status changes. So this is the diagram illustrating what happened in type 2 diabetes. So we have a combination of insulin resistance. So the body is ignoring insulin. We have insulin, but these adipose and muscle cells are pretending there is no insulin. And also the pancreas is not making enough insulin. There has been a link between obesity and insulin resistance. So it is believed that obesity can lead to changes in the secretion of adipose tissue, and therefore this can lead to insulin resistance. And insulin resistance will lead to all of the consequences, the bad consequences that we see when the body is not responding to insulin. So what is insulin resistance? It's when the liver, the adipose tissue, the muscle tissue don't respond properly to the insulin. So there is uncontrolled hepatic glucose production, decreased glucose uptake by muscle and adipose tissue, and increased lipolysis. So as if there is not enough insulin. So obesity is the most common cause of insulin resistance and type 2 diabetes, but this doesn't mean that all obese people will have insulin resistance and will become diabetic. So in other words, this problem alone will not lead to type 2 diabetes. So you have to have dysfunctional beta cells. And how do people get dysfunctional beta cells? The risk is genetic. So there is a high genetic risk or high genetic predisposition for type 2 diabetes. And also the risk increase with time. This is why you will see type 2 diabetes in the elderly and also in individuals who have been obese for a long time, those who are physically inactive, and you see it in some pregnant women who developed gestational diabetes. So insulin resistance is related to weight. So it increases with weight gain and it is diminished with weight loss. So people who have insulin resistance, if they lose weight, they will become less insulin resistant. And again, this is because of the changes in adipose secretion, such as the increased secretion of inflammatory cytokines, which lead to inflammation. And we believe that this inflammation will lead to the insulin resistance. So here a comparison of the blood insulin and glucose level in normal weight and obese subject. Red is obese, blue is normal. This is insulin level. So what is this figure telling us is that higher insulin level are required to control blood glucose in insulin resistant obese individuals. So you can see here the body is making too much insulin following a meal. There is a much sharper rise in insulin in the obese individual compared to normal individual. But if you compare the glucose level, so the glucose level are similar. So in other words, you need higher level of insulin to maintain the level of glucose within normal in obese individual compared to non-obese individual. So why we have dysfunctional beta cells? So it's believed that over time, because the pancreas is being forced to make more and more insulin, as we've seen here, we need to make more and more insulin because of the insulin resistance. Over time, the beta cells will become tired and will become dysfunctional, and they will start making less and less insulin. So you can see here the level of glucose, fasting glucose in untreated type 2 diabetes. So he was diagnosed here with diabetes, and this is how many years he's been having diabetes. So over the years, his blood glucose is going up and up because he started, before getting the disease, he was insulin resistant. So he had to make lots and lots of insulin. And over the years, his beta cells becoming dysfunctional. So they were making less and less insulin and less insulin until his blood glucose started to shoot. So this is how people or type 2 diabetes progress. So we start with insulin resistance. The body is making too much insulin. There is impaired glucose tolerance, and there is a decline in the function of the beta cells, and then there is type 2 diabetes. What caused the beta cell dysfunction? Genetic factor, or some people think that there is a glucose toxicity or free fatty acid toxicity. All these factors together will lead to the decline in the function of the beta cells. What are the complications of type 2 diabetes? We have complication at the microvascular level, so these are mainly retinopathy, neuropathy, and nephropathy, and we have complication at the macrovascular level, and these are the serious cardiovascular disease and stroke.